Good evening. I'm Kyle Bickel, and this is AO Trauma North America Hand Therapy Essentials webinar series. Welcome to everyone from wherever you're tuning in. Tonight's session will discuss nerve compression and nerve injuries. I will be one of the co-moderators with Alpana Joshi, and we have a team of great physicians and therapists online for you tonight to discuss numerous aspects of nerve injury and nerve compression, and both the surgical and therapeutic standpoints of how they're managed. Our faculty tonight includes Alpana Joshi in Minnesota, Phil Blazer in Boston, Rebecca Neiduski in North Carolina, David Dennison at the Mayo Clinic, Stephanie Canis also in Minnesota, and Lauren Grossman in New York. These are the important housekeeping issues with disclosures about financial relationships, and all of these have been resolved prior to tonight's presentation. This session is being recorded, and a link to the recording will be sent out through Zoom 24 hours after tonight's session for all of those who wish to review it. This is the schedule for our series, which started on April 29th. We're now in the fourth week of this with our nerve compression and nerve injury presentation. And we have 3 more sessions over the next 3 weeks on Thursday evenings, and we hope you can attend those as well. Just a brief reminder that we're on Zoom. All of your microphones have been muted and your videos turned off. Please keep them that way during the presentation. We do, however, encourage you to ask questions, and those can be asked in the question and answer box. We will be perusing that throughout the presentation, and we will either address them in the presentation, or one of the faculty members may answer the question in the Q&A box. So please don't hesitate to ask questions during the presentation, but please don't use the chat box for that. So without further ado, we're going to go into our initial overview of nerve compression and nerve injuries. The learning objectives for this session are to increase your knowledge of the roles hand therapists play in the recovery and surgical treatment of nerve injuries and compressive neuropathies. You'll learn how various therapeutic techniques and modalities can improve patient outcome during nerve regeneration and recovery, and you'll develop new treatment strategies to include in your own surgical and/or therapy practices to immediately improve your management of nerve problems. The nerve problems that we face as upper extremity surgeons generally fall into 3 broad categories. There are acute nerve injuries, such as we see here in this ulnar nerve laceration from penetrating trauma above the elbow. And the surgical management generally involves exploration with preparation of the damaged nerve endings for either repair or grafting, depending on what the situation requires. It may involve delay of definitive nerve repair if there's contamination or devitalization of the surrounding wound bed, and it's often associated with bony fixation and/or soft tissue coverage, depending on the nature and the extent of the injuries. We also see subacute nerve injuries. These are injuries that happened in the not too distant past, such as this example of a partial median nerve laceration in an endoscopic carpal tunnel release gone awry that happened about 6 weeks prior to presentation. These differ from acute injuries in that there has already been fascicular retraction and scarring. The wound bed may no longer be healthy depending on the nature of the injury, and there's often muscle atrophy starting to evolve due to the denervation effect and the time issue relative to the time of the injury. And these typically require nerve grafting and/or transfers in order to restore function. And then finally, we see compressive neuropathies. The ulnar nerve is often involved at the cubital tunnel, such as we see here, or at Guillaume's canal. The median nerve, as we all know, is common in carpal tunnel syndrome and less commonly in pronator syndrome. And the radial nerve is less commonly compressed, but can be affected at the radial tunnel and at the radial styloid in Wartenberg syndrome. Treatment for these injuries generally involves decompression with sometimes transposition, especially at the ulnar nerve, and associated flaps and wraps to augment the wound bed and provide some gliding tissue for the nerve to try to prevent fibrosis and recompression. There are functional implications from these injuries that present numerous therapeutic challenges, such as this case here of a delayed ulnar nerve palsy with claw deformity a positive Froment sign, and visible intrinsic atrophy in the interosseous muscles. We see denervation with weakness and atrophy. These often require some form of sensory re-education during recovery. There can be neuropathic pain and require desensitization, and CRPS type 2 can result from the primary nerve injury. These often involve functional splinting in order to maximize function during recovery and some form of occupational retraining in order to get patients prepared for re-entering the workplace and normal life. So that gives us a good background, and Becky Neiduski is going to take it from here and talk about the therapeutic overview for tonight's session.
Thank you, Dr. Raquel. I'll go ahead and share my screen. All right, so today I'm going to do a very high-level overview, keys to rehabilitation after nerve injury, and I will pass on to Stephanie and Alpana to really dive into the cases that the surgeons will present tonight. So the first thing we're going to think about is assessment, and one of the themes I'm certain that you've heard from me over the past few weeks is that therapists have to be great data collectors and really understand how and when to implement assessments that will help us understand whether what we're doing is actually working. So truly, in the cases of patient with nerve injury, sensory testing is going to be a primary means of assessment. I think the biggest problem we have with sensory testing is oftentimes we're not using the right tool at the right time. And so if you look in the left column, you see order of return, what it's mediated by, and what it's measured by. And so especially as we're waiting for nerve recovery or regeneration, we really have to think about working in order and not jumping right to that 2-point discrimination because it's the smallest and easiest tool in our tool belt. So when we think about order of return, we start with pain and temperature that's mediated by free nerve endings, things like hot and cold, sharp and dull. And that's very easily done with an ice pack. Obviously not we're poking people with pins anymore, but certainly the difference between something that's sharper, almost like a toothpick versus a dull intervention. We move into the vibration. So 30 hertz of vibration are mediated by the Meissner corpuscles and quickly adapting fibers. And this is when we use our tuning forks, both for the 30 hertz vibration and the moving touch. It's interesting to me to think as a therapist of when the last time we used a tuning fork was, or whether those are one of the tools that are getting dusty in the closet. We move on to constant touch. We're looking at Merkel cells, Ruffini end organs, and slowly adapting fibers. These are measured by Semmes-Weinstein monofilaments, or a monofilament of some sort, and this measures sensory threshold. I do think therapists are sometimes hesitant to use Semmes-Weinstein just because it takes more time and it's more labor intensive, but certainly it's going to give us a really good picture and certainly a color-coded picture. And I have found that patients respond really well to that color coding of sensory reinnervation that helps them really feel like something actually is happening. We move to number 5, which is 256 hertz vibration. This is where the Pacinian corpuscles and the quick adapting fibers come in. This is our smaller tuning fork, or the 256 hertz tuning fork. And then we get to 2-point discrimination. This is where the overlapping peripheral receptive fields and regional density plays a role. And this is where we use both moving and static 2-point discrimination to assess innervation density. And finally, we move to sterignosis. This is cutaneous receptors in the skin, as well as the peripheral sensory pathways. And this is where our patients are asked to create object identification. So I ask you to close your eyes and put a coin or a paper clip or something small in their hand and ask them to discriminate between a dime and a nickel, or between a paper clip and a safety pin, for example. The other really important aspect of assessment for these patients is manual muscle testing. And this may seem very overwhelming, this slide and all these pluses and minuses, but we know that for our patients that have regeneration or that we're awaiting regeneration after nerve repair or nerve compression, we really need to be very specific and precise in our manual muscle testing and really use the gravity minimized plane. And so what we're thinking about is that patient that has early amounts of nerve reinnervation or muscular reinnervation, we really want to think about putting them in the gravity minimized position to see if they're starting to establish any type of motor power. And when we get to my next slide, and we'll talk a little bit about the difference between adaptation versus remediation, really thinking about where should we be with these patients, because once the muscle is reinnervated, we certainly want to begin strengthening, but we're probably going to need to do that in a gravity minimized plane. So that's a good segue then to intervention. It's incredibly important for the therapist to know what phase of rehabilitation they're in. Are we in the adaptation phase, as demonstrated by all the splints on the top, radial nerve to the left, ulnar nerve in the center, median nerve to the right, and these splints, create actually positions. So they make up for that loss of motor function due to nerve injury. But when those muscles start to be reinnervated, we need to move then to the remediation phase and actually begin strengthening. So knowing when to actually move to that second phase and not spending too much time in adaptation is a really important part of the process and is really well informed by your sensory and muscle testing. Another big part that therapists play a role in is education. We know that nerve injury leads to sensory loss. And what you're seeing in this photo on the left is a temperature gauge on the spigot of a bathtub. And you really want to think about the fact that when people cannot feel their hands, they certainly will burn themselves very, very quickly. And especially, and I put the burn picture of the ulnar nerve aspect of the hand, because it's really easy to lay that side of the hand down and not even know the skin is burning until you actually smell it or sense that something's incredibly wrong. Flat iron in the middle for all of us ladies that straighten our hair. We know these things are 400 degrees is the setting I put mine on this morning. And then on the right, you see the burner. And so really thinking about all the ways that our patients could burn themselves, and will really need to use visual cues as opposed to sensory cues while they're waiting for those nerves to regenerate. And then finally, it's interesting that sensory reeducation has really changed, and it's important for therapists to know that it's very different than it used to be. We now start sensory reeducation immediately after nerve repair because we're trying to preserve cortical hand representation. And I would say in the last 10 to 15 years, we've seen a real shift in therapeutic attention to the brain-hand connection. So stage 1 begins immediately after nerve repair and lasts several months until there's measurable sensibility in the hand via the Semmes-Weinstein monofilaments. And as I said before, that's the sensory threshold level. Our focus is maintaining cortical hand representation. So using sensory imagery, that's actually having the patient imagine being touched in their hands. Cortical visual tactile interaction, the easiest way to describe that is a mirror box, and Stephanie will talk about that in just a little while. And then cortical audio tactile interaction, such as the sensor gloves shown here. And my final slide is the stage 2 of sensory reeducation. This is when the actual, there's measurable sensibility in the palm. So we're looking at a 6.65 or lower Semmes-Weinstein monofilament test. And once some protective sensibility has been localized correctly in the fingertips, touch discrimination and identification can be initiated. Our goal is to reestablish functional reinnervation of the hand via cortical reorganization. So really thinking about that brain-hand connection. And the study in 2015 found that we actually may improve sensory outcome after wrist-level peripheral nerve repair using these approaches. So with that, I thank you, and I'm going to stop sharing my screen and pass the baton to Dr. Grossman to begin our first case.
Hi, so I'll be speaking about nerve injuries and specifically a median nerve injury after a carpal tunnel release. So I'm going to jump right in, and it's there are not a lot of clinical findings. So this was a 59-year-old male who was seen for a second opinion after an endoscopic carpal tunnel release. He had an endoscopic carpal tunnel release with another surgeon. The other surgeon said that about shortly after his surgery, he started having worse numbness. After that, he waited a few months or so, got a new EMG NCV, which showed that his median nerve compression was worse. And so this surgeon took the patient to have an open carpal tunnel release about 3 months later. I don't have any images or any other data besides this from the patient. So afterwards, after he had his open carpal tunnel release, supposedly he saw no abnormality and everything seemed fine. He decided to wait a little bit longer, thought maybe the nerve would come back. Again, I'm not sure how bad his numbness was prior to his first carpal tunnel release. The patient was then sent for another EMG NCV 6 months after the open carpal tunnel release. and there was no change from the one after the endoscopic carpal tunnel release. So after that, the patient was then sent to see me. So it was closer after 6 months, 8 months or so that I started seeing the patient. And he came to me, he felt that his hand was dead. He couldn't feel anything. He didn't have any problems in terms of motion, didn't have a major problem with opposition, but his main issue was not being able to feel anything. So after that, I just took him straight to the operating room for an exploration, revision, carpal tunnel, exploration, neurolysis, possible nerve repair, possible, which most likely wouldn't be able to be repaired after that period of time, possible reconstruction, but I really had no idea what I would see. So here are my intra-op photos. I went in and I did extended carpal tunnel release. And on the left side, we see, this is after major dissection, he had a significant amount of scar tissue around his nerve, and there was neuroma. As you could palpate, it was very firm. And so I did a dissection. And on the left here, the fingers are at the top of the screen and the wrist is at the bottom of the screen. You could see that basically the median nerve was cut, and it was cut where all of the digital nerves ended up being cut. So I ended up doing a nerve reconstruction with Allograft, and I connected proximally with just a conduit for tension-free repair. And after this, the patient was sent to therapy. So my thoughts for my therapist were, what do we do next? And it was more so sensory reeducation for the patient, scar management, nerve gliding, some sort of dexterity, and trying to prevent any type of future neuroma, and scarring of this patient as he's so far out because it's chronic. So now I'm going to pass the baton to Stephanie, who is a therapist, who's going to give her thoughts on this.
Thank you. I'm going to grab my PowerPoint. I think it's really important as a therapist and surgeon relationship to always have those discussions with each other about being open and honest and knowing everything that has been injured. So let me go ahead and start. Are you able to see my screen? But what I want to get out of this one with the median nerve is I want to discuss the protection strategies after the nerve coaptation, and then what type of sensory re-education or relearning principles. And also coming later on, we're going to learn more about the mangled hand. So to begin with, this is a patient who, when I'm thinking in my head, they've already had 2 surgeries. Those first 2 surgeries didn't go well. Now they had the 3rd surgery. Their tolerance for therapy, or they might have, I call it therapy fatigue, in coming into therapy. So that's something I want to keep in the back of my head. But what I would do is if I got the orders from Dr. Grossman, I'd want to see the surgical report, because the first thing I would consider is, was the nerve put under any stress during the coaptation? So if there's any tension on the nerve, I would want to protect that nerve. And research says you can vary that from anywhere from a few days up to 3 weeks. And sometimes it would require full immobilization, but if it just needed a slight bit of protection, it could be where I could just make a dorsal wrist orthosis and just give the nerves and the tendons a limited short arc of motion so the wrist wouldn't get too stiff. But in this case, because I talked with Dr. Grossman, there was no traction or no tension placed on the nerve. And so even with the wrist in an extended position, so this would be a time when I would just let that patient maybe be in a prefabricated wrist support for comfort, but otherwise they can come out and do motion. The other thing I'd really want to know from Dr. Grossman is the level of injury or the level of repair, so I could really think about any possible motor involvement. In this case, there wasn't any motor involvement, but things to think about is, how do I balance the thumb? And I'd really have to do a thorough manual muscle testing as able to make sure all the median nerve muscles in the thumb are ready to go and are working at full strength. So, but I did not have to worry about that with this case. The next thing is sensory relearning, and that's going to be a big component of this talk. I also want to do a lot of edema control. I also want to do scar management, and this is the person's third surgery. So in my experience in therapy, every time you go back in and do surgery, scarring is a little bit worse. And then the other thing I'd want to be on the lookout or keep on my radar is with re-releasing the transverse carpal ligament, is that patient going to have any type of pillar pain, or as some of my physicians like to call it, transverse carpal ligament pain? So the first thing is sensory relearning. And as Becky alluded to earlier, is I need to give this patient protection strategies, how to protect that hand. That is probably one of the most important things, because I would hate for the hand to have a cut or a burn. And so another great strategy is also to have like cut resistant gloves if this person were to have to do a lot of kitchen tasks. And then the other thing is I need to maintain the cortical hand, so the sensory area. And so using auditory feedback, where the patient puts on a special glove and then they listen to headphones, and then whatever they touch in their environment, the microphone brings back up to the ears, and they can hear that they're touching things, and that will help keep the cortical hand alive in the brain. And other things to do is sensory imagery. So one thing you could have your patients do is imagine petting a dog or petting a cat, and how does the fur feel, and having them just sort of imagine and recreate things that they have to touch during the day. And then another thing you could do is you could use a mirror box for that sensory imagery. And you could have the affected hand in the mirror box, and then their unaffected hand on the outside. The patient's just watching the mirror, and maybe they're feeling different objects for, is it rough? Is it smooth? Is it sticky? And those are some nice things to do that you can keep that cortical hand continuing to work. So after axonal regeneration, and that's when protective sensation is detected. And that's one of those good times where you'd want to pull out your Sons Weinstein, and you'd want the 6.65 monofilament, and you would go ahead, and if they can detect sensation, I know I can progress to this phase. Now, if my patient has any allodynia or dysesthesias, I have to do a desensitization program ahead of time. And so the video that's currently playing, that's one of those things you can do where you can grade different textures and send them home with little sensory toolkits is a really nice thing. Another thing I like to have them do is just use objects around the house. And so that can help them as well learn and do that desensitization. In my patient population, or the patients I see, I typically want them to do this 4 to 6 times a day. And then I also want them to spend maybe 4 to 6 minutes at a time. You can also encourage them to use like a rice bucket. In our clinic, we throw different items in there. So for later, as they're starting to discriminate, they can then begin to pick items out of that box. And so we have a rice bucket here at our clinic. We have a popcorn kernel bucket. We have dry macaroni. And so you can really use a lot of cheap household objects that patient can use at home. So with sensory relearning, again, we want to go ahead, and once they are desensitized to everything, that's when they're appropriate for sensory relearning. And so one of the first things we want them to do is we want them to localize touch, because those axons that went into their brain, they're sort of distorted at the moment. And so sometimes just with their eyes closed, you can use an object such as a highlighter or stuff, and I will just be like, okay, what am I touching? And sometimes it takes them extra time to answer because, again, their brain is having to work hard to discriminate. The other things is you can have them hold something that vibrates. So things around the house that would be great would be a toothbrush or a electric shaver, something that has a little bit of vibration. In the clinic, if you have a mini massager, that's really great. And then the next level of intervention I'd want to do with this patient is start to identify shapes and sizes. And then from there, I'd want them to go ahead and start carrying small objects in their pocket so they can discriminate, again, that paper clip from a safety pin. And so those are some of those nice tools that we can use. Other strategies I want with this patient, I want to think about edema control. What type of compression do I need? And then from there, also looking at scar management techniques. In our clinic, you can just go ahead. You can just use 2 fingers with no emollients. That works okay. But sometimes I want more traction, so I'll use a piece of Dyson to give me an additional grip. Sometimes I will use kinesio tape, paper tape, or silicone scar pads over incisions just to help them heal nicely. And you can see I did a basket weave right here because that will help if there's any strong adhesions. And this is just the larger kinesio tape picture is another nice way to help with scar adhesions. So moving forward, the last thing that's sort of on my brain is thinking about pillar pain or transverse carpal tunnel ligament pain. So that would be a time when I can start advancing to soft tissue mobilizations, ultrasound, kinesio taping, and maybe an intermittent gel sleeve. And typically this occurs in my experience around like that 6 to 7 weeks after surgery. So just some nice things to think about. And the entire time too, I'm thinking about fine motor. How am I getting that thumb to work? How is it translating and rotating and shifting objects in the hand? So some take-home points with this case, discuss details with your surgeon. I want to know the level of repair. I want to know motor and sensory expectations, what I should be able to get desensitized prior to sensory relearning. Again, educate patients that nerves take a long time to regenerate. Often they get a little bit frustrated. And then as a therapist, we need to keep cortical mapping in place.
Si sostienes la pierna, pesa. Y lento con la pierna.
Any questions on any of this so far?
Stephanie, we do have a question about parameters you like to use for ultrasound for scar tissue. And then I've got a second one also.
Okay, some of the parameters I like to use is I usually tend to use around 3 megahertz. And then I will do 0.8 to 1.0 centimeters per watt squared. And then depending on the hand, if it's a big farmer hand, I might use my 5 centimeter sound head because the area of ultrasound should be 2.5 times the area of the sound head. And if it's more of a petite average hand, I might use my 2.5 centimeter sound head.
Wonderful. And then Stephanie, the second question is for the kinesio tape for pillar pain, which way is the tape applied?
So sometimes I'll do actually first a space correction technique. So I take the tape, rip the middle in half, pull it at about 60 to 80% tension, sort of stick it down evenly. And then you want to think about the recoil. So a lot of times if I want recoil and I want to open the hand, I'm going to start and apply at the outside portions of the hand and then come medial with my tape to anchor.
Becky, can I ask a question?
Of course.
Those were great. Lauren and Stephanie, this is a great opportunity to discuss conversations with patients and with therapists. So this patient had a devastating problem. And so I'd like to hear from Lauren, what was that conversation like after you found that nerve problem? And how did you relate that to the patient and relay it to Stephanie? And what were the conversations like between Stephanie and the patient afterwards?
So after surgery, I told the patient exactly what I found. I told him that the nerve was cut And I told him that it was a very bad injury, and the fact that it had been so long since the initial injury, I would not expect for him to regain full recovery. I told him actually before going in, and then again afterwards, my goal was to get protective sensation, and that was my goal. I wasn't expecting much else for him. For my therapist, I didn't work directly with Stephanie, but we're gonna make this. I basically said my goal is for sensory reeducation to minimize scarring. I told exactly what had happened to the nerve, and pretty much not to expect to regain full sensation. But the goal was to minimize any post-operative pain, to try and regain whatever the patient could in terms of sensory education, to be able to identify potential objects in his hand, and to hopefully the goal is to not burn himself and, not realize that he's the one who's cooking.
Lauren, I assume given the location of this injury that the motor branch was also involved, and did you specifically isolate and graft to the motor nerve? And if so, did you have any feedback or input to give to Stephanie in terms of how she might focus on rehab? We've talked a lot about sensory reeducation and motion, but we haven't really talked about protection and return of function in the thenar muscles from this injury.
So I did directly graft it. I did mention it as well. The patient didn't seem to have a significant problem with opposition or the use. So I didn't think that it was something that was as important, at least in my eyes, since it had been going on for more than 6 months. The patient was doing well. He didn't notice any issues with that. I did mention it and let Stephanie know that's something to look into, but I think the patient's main complaint, and I geared it towards the patient's issues or the patient's complaints, was the sensation. So I was a little bit more focused on that.
And so just to follow up, I think, Kyle, the technical aspects are really important, but just in terms of the conversations between the therapist and the patient, because therapists are they're named therapists for more than one reason, because they'll tell therapists a lot of things that they're not going to tell the hand surgeon. So how would that kind of conversation go?
So good question. So I think a lot of times when we see the patient after the surgeon, a lot of times they do open up and they might express more anxiety that they're really hopeful that this works, but sometimes still in their head, they might have a little bit of doubt because they've already had 2 failed surgeries. So a lot of times it's trying to get them to maintain the confidence in the repair, in my experience. And then again, a lot of them have sort of therapy fatigue. So if they already went to therapy for the first 2 surgeries, they feel like they might know a lot of things. But I think it's really important where you have to stress and listen to them and actively acknowledge their concerns, and then get them to buy into really taking an active role in being a participant in therapy so they can do their sensory relearning. If they need to do motor relearning, they have faith that, yep, I can wear this splint. And then when the nerve starts to return and they're noticing that they're getting little twitches, or if there was an EMG to show that reinnervation has occurred, I can start that gravity eliminated strengthening program right away, so I can really maximize the strength I can get back into the intrinsics.
Okay, Lauren, can you, for the sake of the therapists here who may or may not be as experienced as some of the others, can you walk us through your decision-making algorithm as to why you went with allograft as opposed to using more traditional forms like sural nerve?
So I used allograft because there were a lot of nerves that were cut. I was concerned about having enough nerve. to be able to graft, and in terms of thickness and cable grafting, and I think it was about 5 nerves I had to do. So I think that was part of it. Also, part of it was it had been it was a long period of time. There was a significant amount of scar tissue. So I think if I had gotten to it first or right away, I think something like that would have been a little bit easier, but there was so much length at that point. I just felt that that was the easiest and something that I would actually be able to get done. So I was concerned regarding that. And in addition, I think at least some more recent studies have been showing that allograft for sensory has had pretty good results. And so to minimize donor site morbidity as well.
Would you feel that that alters your management and your communication with your therapist in any way, shape, or form? The kind of graft you use, and do you let them know that?
I do let them know what I've used. In terms of what I've used, I think that if I had used Searle, I probably would tell my therapist so they could pay attention to the foot also for the donor site, to be honest with you. In terms of the education and for this specific issue, I didn't think that it necessarily changed management much.
Great.
Thanks, everybody. That was a good discussion. I think in the interest of time, we have a few more cases to present. There are some questions from the participants in the Q&A section. So if any of the therapists could hop onto the Q&A during the next presentation and answer those questions, that would be much appreciated. We're going to go on to the next case, which is going to be presented by Dr. Blazer, and he'll take it from here.
Thanks, Kyle. And everyone, welcome. Okay, sharing my screen. Hopefully everybody can see that. So this is a quote, high ulnar nerve case. So the patient is an 18-year-old right-hand dominant male who presents with a laceration of his right upper extremity. The laceration is in the medial upper arm, and the injury was sustained while attempting to catch a Frisbee and fell through a plate glass window. So on physical examination in the emergency room, the upper extremity has a fairly sizable triangular shaped laceration extending from the axilla distally into the medial arm, was about 10 centimeters from its apex. On exam, it was noted that there was no strength in the FDP to the ring and small, no interosseous function was noted, and no light touch over the ring and small fingers. The patient had significant bleeding and a tourniquet was applied prior to coming to the hospital, but the patient did have dopplerable, if not palpable, pulses in that extremity. And here is an image of the arm. The patient's head is to the top on the day of injury with that tourniquet being seen at the edge, still in place. And you can see this is certainly a deep injury there. So on the day of injury, particularly because of the significant bleeding, the patient underwent a surgical procedure, which identified a partial brachial artery injury, which was repaired directly. The ulnar nerve was unfortunately found to be lacerated, and it was repaired with an epineurial technique. And because this was a glass sharp laceration, we were able to do this primarily with minimal tension. The traumatized flap was mobilized and closed. Oh, sorry. And so the patient returned. And this is the situation we're faced with at about 3.5 weeks after injury. The patient's recovered. The initial surgical scar and traumatic wound are healed. And the red arrow is approximately the location where the nerve had been repaired. So our situation at this point is we have an 18-year-old male with a high ulnar nerve laceration that was repaired at a distance approximately 6 inches, not centimeters, above the medial epicondyle. And at this point, we have a couple of options to consider, and they're listed here. And quite clearly, this is not his image, but the positive Froment sign certainly would have been true or was true in his situation at that time. So certainly, I think one can make an argument to say, all right, young person, let's await the results of this repair. It was done without tension and has some potential for a good recovery. Tendon transfers are well described for the ulnar nerve injured muscles to replace them. And that's a consideration. And certainly the concept of nerve transfer is applicable for injuries like this. So briefly, after discussion with this patient, we decided to do an interosseous nerve to ulnar motor nerve transfer. And the rationale behind this was that the physical distance from the laceration and repair of the nerve to the intrinsic muscles, which are very key to the ulnar nerve contribution to hand function, was about 20 inches. In primates, the basic science and clinical data indicates that the return of axons after about a month for that process to start occurs at about 1 inch a month. And so at 20 inches, it becomes very relevant that the other process in primates that is quite true is that the motor end plates through which nerve signals are translated into muscle action begin to be completely unreceptive to those regenerating axons, even if they get there after a period of somewhere between 12 and 18 months. So with this injury, the assumption is that it's highly improbable that he's going to get intrinsic function. So to try and restore that, we do this AIN nerve transfer. And here is a close-up view of the ulnar nerve, which has been dissected at this level anatomically in the distal forearm. And the hand is to the left and the elbow to the right. The sensory and motor fascicles can be separated atraumatically and fairly easily. The forceps is holding the sensory fascicle, which is the larger fascicle displaced anteriorly. Moving slightly more laterally through that same incision, the structure just above that forceps in the middle is the Antiinterosseous nerve, where it has been dissected into the pronator quadratus. And it's worth remembering that the deficit for sacrificing this motor nerve is only the pronator quadratus, because the other antiinterosseous innervated muscles that we're all familiar with are innervated more proximally with other branches of the interinterosseous nerve. In this case, we elected to do a so-called end-to-end transfer where the motor nerve was cut because we did not think there was much potential for recovery from the repaired nerve. And hence the motor nerve was cut and brought over to the antiinterosseous nerve that was cut. And you can see the microsutures there in the middle. And we follow the principle dictated by those of us who, by those who have taught most of us about nerve transfer, that the donor nerve, in this case, the AIN, you want to be distal to get it as close as possible to those intrinsic muscles that we're hoping to reinnervate. So I'm going to pause there and ask Alpana to help us with the therapy questions. Let me stop sharing my screen.
Thank you, Dr. Pleasure. So let me share my screen here. Are you able to see my screen?
Yes, thank you.
Yes, we can.
Perfect, thank you. So let's talk about the rehabilitation of that patient after the ulnar nerve repair and the AIN to distal ulnar motor nerve transfer. So as a therapist, you want to know what the exact findings at the event of trauma was. He had significant bleeding, which could lead to significant scarring. He also had a partial brachial artery that was repaired and complete ulnar nerve laceration at the time of injury, the day of injury, was repaired through epidural repair and minimal tension. In about 4 weeks, and this is something that you find out talking to the surgeon, that in about 4 weeks, he underwent the AIN to distal ulnar motor nerve transfers. He did not have any bony lesion, which actually is a good thing because then you don't have to deal with fractures and things like that. And the wound was closed on the day of injury. So as a therapist, I'm also thinking he's a young man, his dominant arm is involved, so there are a lot of functional implications to this. You want to talk to the surgeon about any range of motion restrictions after the nerve transfer. What exactly is the surgeon expecting? What is the plan? You talk to the patient about his support system, what his goals are, does he have any access to local therapy, and if he has any comorbidities. So there's a lot of communication between the therapist and the surgeon, and between the therapist and the patient himself. So you need to get all this information before you plan the treatment. Now, before we go into the specifics of rehabilitation, I wanted to kind of highlight the high versus low ulnar nerve lesion differences, wherein you are looking at, as we discussed last week extensively about the function of lumbricals being primarily the MP flexors and IP extensors. We lose that in both high and low ulnar nerve lesion. When it comes to a low lesion, you are looking at loss of MP flexion and loss of IP extension, wherein now the EDC is pulling that MP into hyperextension. However, you do have the FDP to the ring and a small intact. So that causes that IP joints to be pulled down by the long flexors into slight flexion. However, in a high nerve lesion, you have lost, or the FDP is now denervated. So you really don't have that flexor pull, and you don't see, and you don't see the typical ulnar nerve lesion of the claw hand presentation with a high ulnar nerve lesion at the time of injury. However, as the nerve regenerates and the nerve advances, you could start seeing, and you will start seeing, the claw hand with a high lesion, and that's actually a good sign, and that is something that you need to let the surgeon know, let the therapist know, let the patient know, and tell them that this is a good sign showing us that actually the nerve is doing what it's supposed to do and advancing. Now, when it comes to the functional implications between the high and low, if you are putting the patient into an anti-claw splint with a low lesion, with the FDP being intact, the patient is now able to functionally use that hand because now they're able to grip and grasp things. Versus in a high lesion, even if you have them in an anti-claw splint, the person will have difficulty making that power grip. So that's a big functional loss for a patient with a high lesion. So something to kind of think about and keep in mind. It's a good way to educate the patient, and I'm a big believer in patient education. So let the patient know what to expect, what they need to look for. So since this is a really long process, the patient has to be aware of what the expectations are. When it comes to rehabilitation, these two articles are very helpful. The donor activation focused rehabilitation approach, or DAFRA, by Lorna Khan and Dr. Moore, and the rehabilitation of the upper extremities following nerve and tendon reconstruction by Christine Novak and Rebecca Wonderhide. They have laid things down really well. DAFRA protocol is when you use the donor muscle action to send the messages to the recipient muscle. So you're using the donor muscle action to send the messages to the recipient. This is important to understand. The other thing it also uses is the concept of cortical plasticity, where the altered neural pathway cause adaptive changes in the sensory motor cortex due to intense training and repetition. The intense training and repetition is important for the patient to understand. And these two factors have to be explained to the patient. Now, when it comes to rehabilitation, they have, let me go back here. They have divided it into the early, middle, and the late phase. So during the early phase, which is right after the repair, the patient comes to you. If the patient has had nerve repair with no tension, you really don't have to worry about any specific nerve coaptation protection. However, when I spoke to Dr. Blazer, he talked about he had the patient move the elbow and the wrist and the forearm pretty freely, however, limited his shoulder motion to protect the nerve coaptation for about 3 weeks or so. So he was required or advised to use this sling, but I guess when he came back at around 3.5 weeks, he didn't have the sling on. So you can always see that. So that's one thing that you want to let the patient know in terms of protection. It involves a lot of patient education. The patient needs to know that this is a long recovery process. They need to understand that nerve regeneration is very slow, like it has been highlighted earlier. And it is important to teach at this time itself the donor action rehab or the DAFRA process, because this will help the patient kind of begin the process of understanding what they have to do and what their role is to activate the transfer. The second thing, like Becky mentioned earlier, it has been shown if you start the sensory re-education process early, right after the repair, using motor visual feedback, mirror therapy, or even localization, observation of touch, you do see a good sensory function or improved sensory function during the first 6 months of after surgery. So that's important for the patient to understand that also. Protecting the skin because you have the sensory loss. As always, work on the wound, work on the scar. It's very important that the nerve that's passing through all of these areas need to be gliding well. Manage the edema, manage the pain, keep in touch with the doctor regarding if the patient has neuropathic pain and things like that. Maintain the range of motion. You have to maintain the range of motion of the joints that the nerve supplies, because even if the nerve starts working and the joints are stiff, they will not be helpful. And positioning. In this case, I've used McConnell taping. You could use any kind of material for the anti-claw splint. And at this phase, you also don't want to use a lot of visits, because you know that after you have educated the patient, you have to take a back seat and let the patient do all this work. This is going to be a few months before you can start seeing the motor recovery. So, and then at the time of motor recovery is when you would probably need more of those therapy visits. So you don't want to use too many right now. Going into the middle phase, which is primarily the sensory motor re-education phase. It is the remediation phase that Becky was alluding towards earlier. It involves motor recovery. As soon as the patient, or as soon as you see signs of any kind of reinnervation, that's when the patient moves into this phase. And that's why the patient education in the early phase is important as to what they should be expecting. You can continue with the donor action rehab. You want to flood the recipient muscles using the donor muscle action. So in our case, the AIN, which supplied to the pronator quadratus, was using, so we have to use pronation to activate the intrinsic muscles in the hand. So here you see the forearm is in pronation. I'm using biofeedback that helps the patient understand if the correct muscles are being activated or not. That gives an auditory feedback and a visual feedback at the same time. Sensory relearning, you want to talk about bilateral movements, because bilateral movements are also shown to help with motor or cortical remapping. If the patient has any hyperesthesia, you want to talk about desensitization. I just picked up things around the house and made us a desensitization kit. Does not have to be anything formal. When the muscles, as the muscles are getting stronger, you usually start with active assisted exercises, gravity assisted exercises, then go over to gravity eliminated exercises. Once the patient starts doing place and hold, that would be the time when the patient would actually go into the late phase, where the goal now in the late phase is to gain that isolated motor control. This happens over time. This will take time. As soon as you start seeing the place and hold strength, you want to have the patient do more strengthening activities. However, in the meantime, you want to avoid fatiguing. So it's more low resistance and high reps. So you want to do endurance training with the patient. Once the patient starts gaining more isolated motor control, you want to start introducing functional training, in-hand manipulation skills. And this also kind of incorporates sensory feedback and all of that. You can have intrinsic strengthening in various different manners, using a paperclip, using clothespins and things like that at home. And also, at the same time, don't forget the proximal strengthening, because it's been months since the patient, or even years sometimes, since the patient has been using that arm normally. So the proximal muscles are going to be weak. So make sure that the entire upper extremity, upper back is being addressed. If the patient ends up having residual deficits, then that is something that you would then talk to the surgeon.
That's great, Alpan.
We can't hear.
I'm sorry, do we have any questions from any of our other faculty, or any comments? Becky, I know that you were obviously very involved in the donor activated rehabilitation protocols as they are being developed. Do you have comments about that?
No, I think the one thing that I learned in that process in working with Dr. McKinnon and Dr. Moore and Lorna Khan, who's really brilliant, and Chris Novak to lift all of those people up, is that really I think therapists shouldn't be afraid of working with these patients, and really taking the time to just understand the anatomy, understand the nerves that have been taken, and what they're being a donor for is really, really important. But I don't think people should be fearful about those procedures, because I think therapists can have really great outcomes if they follow those protocols pretty closely. So I think it's just really exciting to get to work in that space.
Thank you.
I'd like to add one point to that. I think too, when you're looking at someone who has a muscle grade of 1 and you're trying to do a DAFRA approach, sometimes it's really great to use even a little single channel biofeedback unit, so they can actually see on a light that they're activating the muscle, because they may not see it.
Good point. All right, that was great. And for the participants, please feel free to ask questions in the Q&A, and we'll get to them even if they're at the previous or about the previous presentations. If you have questions, please don't hesitate to ask, and we're going to try to keep moving on so we can stay on time. Our next presentation is going to be from Dr. Dennison, and he'll take it from here. David?
Thank you, Kyle. So I'm going to hope that will be visible to everybody there. Okay, hope you guys can hear me. Good evening, everybody who's hanging in there.
We can see you and we can hear.
Very good, thank you. So we're going to move on a little bit, and in the interest of time, I'm not going to go into great detail about the exact surgery, but to present sort of the challenge. As Stephanie said months ago, I'm going to need a good case for this AO discussion in the evening, so we put this together. But this is sometimes we've talked about nerve injuries that have occurred sort of by themselves a little bit, but that's not always how we really see them. And the objectives for me are really just I'd like you to appreciate the importance of a team approach with the hand therapy team, which includes the patient, of course, and be able to outline the combined approach and how you're going to help guide the therapist and the patient, because they will need some direction from what was inside. And listen to the hand therapist. I learn a ton from them every single day. So this is just to kind of quickly introduce our challenge. This is a 45-year-old male who was drunk. He was suicidal. He put his hand across the table saw 1, 2, and then a third time on purpose. He then went to his car, woke up the next day like this, and did go to the emergency room. So we can see this is a problem. This is skin. This is everything injured. This is going to be not only difficult to fix, but certainly to expect nerve recovery and any reasonable function in his hand. Nonetheless, we also look on his x-ray. It goes down to the bone. So it's pretty much every level on the front of the wrist. And in the interest of time, I would just say that we have to think about that. Everything is cut here. And when I later talk to Stephanie, I'm going to try to give her, categorize each injury, tell her what we can do, what we can't do. But certainly, as we all know, when all these structures are injured, including the skin with this segmental injury, it's going to be a challenge. So we want to try to make sure that do the best we can, which means getting into the operating room and washing it out, of course, starting deep, fixing the bone, the ligaments. We secured the radial artery was segmentally injured, so we did not fix that. The ulnar artery was repaired. The tendons are repaired. And unfortunately, when you have the saw injury, you have a kerf or a loss, and we're not shorting the skeleton. So we do have an area where we're going to have to be mobilizing the nerve a bit and trying to repair it. And fortunately, in this case, he only had one cut in each nerve. It looked like I was worried he might have segmental injuries to the nerve, but fortunately he did not. Same with the tendons. They were pretty much all in one layer deep. And that was a very nice thing to find. So again, we're going to fix everything, the tendons, the ulnar artery, the ulnar nerve and median nerve. And then we're going to report, and this is the most important part, is I'm going to come to the finish. We're going to finish the surgery, and I'm going to call 46121, and I'm going to ask Stephanie, like, we have to get going with this. And the biggest problem is that I fixed the ligaments. You can't extend the wrist. We fixed the flexors. It's a 4-strand 3-0 repair. The ulnar artery is repaired. The median ulnar nerve was repaired with an 8-0, which is something we were taught that if you can sew it with an 8-0, it's not too tight. We mobilized, we did everything to minimize this, but we can't really extend the wrist. It's got to stay a little bit flexed. And that's going to inhibit the ability to really facilitate great tendon excursion when we can't use our wrist motion as much. And then on top of that, Stephanie, here's the skin problem. So we've fixed it. We've tried to make it as stable as we can, and we've made a good handoff. And I think hopefully that gives us a little bit of a launching pad. And so we're going to make a plan with the therapy team. And this includes, in this case too, this patient was suicidal and has to be a part of the team. And fortunately, he had good care for that. We all talked with him, Stephanie, many of the therapists, and his sister who came with him. And fortunately, in this case, he was doing well and able to participate in his care very well. Still going to be an uphill climb. Combined visits are across the hall. We talk with each other every time the patients are in. And again, rehabilitation is a team event for these hand injuries, including the patient. So with that, I'm going to kick it over to Stephanie, who did a wonderful job with this patient, and she's going to show me how it went as well.
Thank you. And I have to give credit to my colleagues that extensively worked with this patient. I had the good fortune of meeting this patient yesterday. So tell my colleagues on the call, thank you. And I would like you to know, when you talk to Dr. Dennison and he calls you, he will say, "Hello, Stephanie, this is Dave Dennison." And then you know you're going to get some interesting patient and you're going to need to put your critical thinking cap on. So like Dr. Dennison said, there's lots of considerations with this person, and we just can't consider just the forearm in the hand. We have to think about his entire well-being, including his mental health. And so this is one of those times where I want to lean on all my mental health colleagues, including occupational therapists out there, and help us get a good plan for this patient. And it was nice. This gentleman had lots of active support, and he was determined to get more healthy and develop some healthier coping strategies versus trying to saw his forearm off. So really the timing of therapy for this gentleman is everything. And now I have to think about vascular nerve, tendon, bone, ligament. So I got to think about all those things. And I also have to, sometimes I'm going to go back to Dr. Dennison and be like, okay, I just processed this up, but I'm struggling here. Why can't I move yet? And it's very great to be collaborative because he can help me. The other thing is this gentleman cut his ulnar nerve, his median nerve. He only has a radial nerve left, and I have to think about extrinsics versus intrinsics as well with reinnervation. But then to complicate this, I have all flexors are injured. I also really need to think real diligently about edema control, because that's going to really play a huge part in my tendon rehab. Scar management again for this gentleman, and wound management of that forearm is critical to minimize any scar adhesions that may limit flexor tendon glides. And then there's going to be a lot of orthotic management considerations. I also had to think about how well is my patient going to adhere to this program. So when I'm looking at everything, do I trust this patient in a dorsal blocking splint, or does he need to be immobilized longer? And then on top of it, I really want to be client-centered focused with this patient. What are his goals? What does he want to get back to? In this case, this gentleman owns his own business. He wants to get back to landscaping. So the therapist that worked with him had a huge role in working with him. So Dr. Dennison called us, and we saw the patient about 12 days after surgery to protect the nerves and the arteries. And you can see our orders where the gentleman had a carpal tunnel release. He had an ulnar nerve and artery repaired. He had a median nerve repaired. Repairs of the FDS, FDPs, the FPL. FCU was repaired with a graft. And then pulvar tap weave was also reused. Things I like to know, because sometimes that's such a big laundry list, is what did they not repair? And in this case, I also have to be somewhat careful because they didn't repair the radial artery. I want to make sure I don't do anything to the ulnar artery. And the FCR was not repaired. So Dr. Dennison asked us to do a modified Duran protocol, which is great. We're going to put this gentleman, his wrist in 20 degrees of flexion. That's going to help protect his nerves. With the MCPs, I'm going to go a little bit more shy and put them at about 40 so I can get a little more excursion. And again, in this splint, his thumb needs to be included. I want to be somewhat aggressive with my edema control strategies, but make sure I don't do anything to hurt the artery repair. So that might be a discussion I need to have with Dr. Dennison and say, how much compression can I use? And then wound management. That's one of the most crucial things, is we got to get that wound to heal. I find in tendon injuries and nerves as quickly as I can to minimize that scarring. So those are sort of all the things I'm thinking in the back of my head with this gentleman. Nerve considerations, again, he's going to be in a splint, but he's a sensate in the median and the ulnar nerve distribution. So I need to make sure that he takes his brace off and he visually inspects his skin. So he uses that other sense to make sure the splint I made him is not going to cause any pressure sores and cause any more open wounds, because if that's the case, I just created a whole new problem. As muscles begin to re-innervate, or as the tendon healing becomes stronger and I can start doing more active motion and pull, I need to make sure I have a balance of my intrinsics and extrinsics. And then we're going to be doing some motor relearning, especially in the hand with all the intrinsics, and then sensory relearning as well. So that's basically the nerve considerations I need for this gentleman. As I continue to go, we saw this gentleman, we did the modified Duran. We talked extensively with him on his goals. And the gentleman, his goal was to get back to landscaping, and he needed to have a power fist. And so the therapist worked aggressively with them. They used compression. We continued to modify that modified Duran protocol. We did desensitization massage because with any dysesthesias. And I had the pleasure of meeting this gentleman yesterday. He agreed to let us take video for this presentation. And the other thing we haven't talked about was, this was his non-dominant hand that he injured. And so when you're looking at these videos, he's really using it as a helper hand, and it's doing a great job stabilizing items. It's pretty functional. But when you look at his arc of motion, and we'll move on to here, you know, things that I could say, oh, this would be great, and this would be really optical. I would have tried to maybe put him in an anti-claw splint that held his thumb in more opposition. But to this gentleman, that was not what he wanted because it was going to interfere with his work. And so when we have those types of discussions, we need to be really frank with the patient and be like, okay, if you don't wear this splint, this is what you need to look out for. Are you going to have contractures of those PIP joints? Is your thumb going to stay more out in an abducted position and have difficulties going into an opposition? And so with this gentleman, he agreed to be very diligent with all of his exercises, in which he was. But then at night, we had to put him in 2 different splints. So one we had to look at for the nerve. And so every other night, he wore the top splint, that intrinsic plus splint that held his thumb into a nice C position. But then on top of it, we have extrinsic tightness if you looked at that video. And so we also wanted to stretch the flexors back out so he could get more extension and get a better glide. So then on his opposite nights, when he's not wearing the intrinsic plus splint, he's wearing that extension splint. And so this was a time when we really, really compromised with this patient, had those frank discussions. And we also negotiated with him how often he needed to come to therapy and to make it work for him so he could be successful at redoing those activities such as working that gives him joy. And so this, again, would have been that ideal daytime splint. I just wanted to show people what it looked like that I would have maybe thought about putting him in. But for him, it wasn't what he wanted. And so we respected his wishes. The other thing, when we're looking at all of these hands, especially like a mangled hand such as this, when I'm the hand therapist, I really need to go back to the roots and look at what my 11 essential hand functions are. So I need to look at all my different grasp patterns and my pinch it patterns, and then my in-hand manipulation, and just really document what he can do and what he can't do. And then just every time he comes in, have those conversations and be like, hey, today, what do you feel like you need to work on? Or what are you noticing you're having difficulties at home? What can I do to help you get more of this? And having those really frank and conversations and work towards his goals so he can have that meaning back in his life. So this case is one where we're still talking with Dr. Dennison on a routine basis. But when you first start, really get specific and get those surgical repairs and those details. Be specific. If that surgeon who referred that patient to you, if you don't share an office with them, get the operative report so you can really read line by line what they did, and then you can make the best plan approach. Like Dr. Dennison said, this is a team approach. So it's the patient, it's the surgeon, it's the therapist. But really, Dr. Dennison plays maybe 20% of the role. Therapy plays maybe 20% of the role. And really the outcome is patient dependent on their adherence. And luckily in this case, this patient was. And then again, you need that multidisciplinary team approach, especially after that mental health crisis.
That was great, David and Stephanie. Really amazing outcome from a terrible injury. So kudos to both the therapist and the surgeon. David, do you have any feedback in terms of your thoughts about how it was approached and how you got such a great result? I mean, as a trauma surgeon, I always tell my patients that I get the easy job and that the patient and the therapist have all the hard work ahead of them.
I would completely agree. This was something, I think one of the things that just would highlight a little bit is that he did start at 12 days, but we often put a splint on that allows him actually, so it's more of a dorsal splint. So if he happens to pull down in his sleep or anything, there's nothing in front of the fingers. So he's still kind of wiggling at that point. So we get that going to get that through 5-7 days, and then a little more, dedicated therapy after that. I think the other thing is that his outcome right now, he's not that far out. Stephanie, I think maybe 4 or 5 months now, something like that.
22 weeks.
Yeah, so he's not like a year out. So we're still hoping maybe he'll get a little more back and some other things. But yeah, we clearly had the easy job, a couple hours of work and then there you go. But I think the biggest thing for him was fortunately that he was interested, he was getting better. And I think one of the things we didn't talk about is that he did not have significant nerve pain. And I hope that maybe that was due to a reasonable nerve repair. But he did not have significant nerve pain, and that was a big help.
That's great. All right.
Can I just add one more thing? As a therapist, and if you're working in an isolated clinic and you don't have direct contact with the surgeon, I think the one thing that really, really helps for therapists to understand what's going on with the patient, if the patient comes in with the prescription and a copy of the op report. That is significantly important, and I cannot even highlight how important that is for the therapist to really plan the program, because we need to know what has happened. And we are living in an ideal world where we can access all these pictures and EMG and all of that, but honestly, in a standalone clinic, it's not happening. So I think it's really helpful if the patient comes in with an op report.
Yes, I agree completely. All right, one last case to present. Yes, Becky?
Can I ask the therapist one more question?
Sure, of course.
Stephanie and Alpana, do you foresee that there's any role for eStim or TENS in this type of case, or the cases we presented tonight, even in nerve, kind of after a nerve repair? What's your thought on that?
So there are some recent articles coming out there on using eStim after I believe some carpal tunnel releases and median nerve repairs, that it's accelerating the repair or the recovery. And so I think that's an interesting frontier that's developing. And so there could be a possible role for that. But I would want to make sure if I was going to do TENS or eStim, you got to proceed with caution, especially if the skin is asensate, because you could damage that skin.
I agree with Stephanie. I think the sensory portion of the asensate skin is really important to keep in mind when you're using any kind of eStim units.
Good question, Becky. Thank you for sharing that. All right, I'm going to share my screen and we'll go on to the last case presentation. And we've talked a lot about traumatic nerve injuries tonight, but let's not forget that most of what we see in the upper extremity clinic in terms of nerve management has to do with compressive neuropathies. So this is a 34-year-old man with a 9-month history of ring and small finger numbness and tingling. And he noticed that his hand was becoming weak, and especially that he was losing some coordination in the hand over time. So we started, of course, with a physical exam showing a Tinel sign at his cubital tunnel. A flexion compression test at the cubital tunnel was also positive. And I checked his coordination with decreased rapid alternating finger crossing and noted that compared to the contralateral hand, he was much less facile with that. He was just slower and had a hard time crossing his fingers. However, there was no atrophy noted in his intrinsics, and he did have subluxation of the ulnar nerve at the cubital tunnel with flexion and extension of the elbow. So the next step was neurologic testing with nerve conduction studies in DMG, and these showed increased short segmental latency across the cubital tunnel, decreased velocity across the tunnel, but normal EMG. So the diagnosis based on his history, his exam, and the studies was moderate to severe left cubital tunnel syndrome. The first thing I did was discuss the problem with the patient and recommended conservative management to see what an impact that might have. And this consisted of nerve gliding exercises. I discussed with him some behavior modification and changes to his environment, elbow splinting at night to prevent compression and flexion. And unfortunately, he didn't experience any improvement in his symptoms or physical findings after a 6-week trial. So the decision points then were that this patient has moderate to severe cubital tunnel syndrome. This is not mild neuropathy. He had no improvement with an appropriate course of conservative management, and he did show subluxation of the nerve at the elbow. And in my hands, this really led to the decision to proceed with submuscular transposition. So I'll just go over the clinical images very quickly and then turn it over to Alpana to discuss the therapeutic management. The nerve was decompressed from the medial intermuscular septum, which is proximal on the left, all the way into the FCU muscle and fascia on the right. The medial antebrachiocutaneous nerves are vulnerable in this discussion and have to be carefully dissected out and preserved, and you can see those there. And there was thickening noted as the nerve was riding back and forth over that epicondyle, leading to epineurial scarring and fibrosis. After the decompression, the muscle tunnel is preserved, and I prepare these in a step cut fashion. So the flexor pronator mass is elevated off of the medial raphe proximally and then distally into the FCU muscle to give us a nice long repair. The nerve is transposed, and then I make a point of flexing and extending the elbow to be sure that the nerve is not kinking or caught in the muscle transfer at any point in time. And then finally, the muscle and fascia are repaired over the nerve in a lengthened fashion so that proximal most muscle elevation is now repaired in a distal position, and that takes the tension off of the overlying muscles and their effect on the underlying nerve, and that allows passage of a finger under that tunnel. I then pass this off to the therapist after a 10-day course of wound healing and rest and a bulky bandage, and we look at a number of different issues, which I'm just going to outline here without going over them in any detail so that I don't steal Alpana's thunder and she can talk to you about the rehab after submuscular transposition for ulnar nerve compression. Alpana, it's all yours.
Thank you, Dr. Pickle. So let me share my screen here. So let's talk about the rehab after the surgery, and we'll hint upon the points that Dr. Bickle just had there briefly. So post-op rehab, the patient comes back for suture removal. Until that time, you want to work on pain management, edema management. Don't forget the proximal portion, make sure the shoulder and scapular motion is intact and the digital motion is intact. After the sutures are removed, that's when you want to think about motion. However, you want to protect the flexor pronator origin. In this case, it was elevated, and you do not want to have the patient go through any composite and extensive motion of the elbow, forearm, and wrist altogether. So during this time period, you want to protect the flexor pronator origin. This can be done using a long arm orthosis to protect when they're not exercising. However, depending on what kind of surgery the patient has had, which again involves the therapist talking to the surgeon, some surgeons might just recommend a wrist orthosis that prevents a composite motion, and then they allow free elbow motion. So it's important that you talk to the surgeon to know if the patient needs a long arm splint or they're okay with just a wrist orthosis. You want to manage their pain, manage the edema. The edema can be managed through compression, elevation. We can also use kinesio tape. Scar can be managed starting with scar massage in about 2 or 3 days after the sutures have been removed. Now, scar massage is plays an important role in this surgery, or any surgery for that matter, but especially this because it's so close to the nerve and the nerve has been moved around. So make sure the patient is educated on the importance of scar massage. I cannot stress this enough because we talk about pain, swelling, the splint and the motion, and the scar massage kind of gets lost in the discussion. So that is something that the patient has to understand, how important the role of scar massage is. You can start with what's called neural mobilization or flossing. You do not want to cause any nerve tension when you're trying to help the nerve glide between the tissues in its new place now. You have to remember now, instead of posterior, it's now anterior to the axis of elbow motion. So you want to avoid that extension, the forced extension of the elbow. You want to keep the flexor pronator mass on a slack. So you want to have that forearm in pronation whenever possible. So trying to avoid that elbow extension with supination and wrist extension at this time is important to know. Sometimes when the patient does not have as much pain, they tend to forget. So they just go ahead and functionally reach for things. So that is something that you want to explain to the patient. Sensory relearning, again, this patient has had this problem with sensory issues and motor issues for the past 9 months. So you have to remember that you want to let the nerve understand the new place, and you also want to provide different sensation to the area that the nerve is innervating. Using using mirror image, mirror visual feedback, I think helps significantly for a patient who has this for a chronic term, and you want to start establishing that connection of the hand with the brain. You can use bilateral movements that are also shown to help with cortical remapping. Again, I'm big on proximal engagement. Make sure the patient has good posture, because when the patient usually comes in after such a surgery, they're kind of leaned over and hunched up. So make sure you talk to them about proximal engagement. Make sure you talk to them about posture. Continuing with the rehab, by 6 weeks, you should hope to have full range of motion. You can begin active assisted range of motion at around between 4 and 5 weeks, continuing using of the orthosis between exercises at nighttime. At around 6 weeks, if you still don't have a full elbow extension, then you can start having the patient use a nighttime elbow extension orthosis. If the patient feels kind of a little bit vulnerable when they go outside, they can use the long arm splint for during the daytime for protection. You can initiate passive range of motion in hand manipulation skills and hand strengthening, more of grip strengthening, because we're talking about the ulnar nerve, and power grip. At 8 weeks, you can work on a lot of proximal strengthening. You can initiate elbow, wrist, forearm strengthening, and get that power grip more functionally being used. And about 10 to 12 weeks, you can think of referring patient out to return to work programs. If a patient is engaged in anything heavy at work, then you might talk to the surgeon and see if maybe the patient needs to wait a little bit longer before going back to work, and continuing with the return to work programs about 4 months or so since the surgery. Even after going back to work, if you feel the patient is going to be engaged in activities that might make him prone to any other repetitive trauma, compression neuropathies, talk to the patient, educate the patient about activity modification. It's important that you educate the patient why this may have happened in the first place. So you want to educate the patient about how you can modify the activity at work, height of the desk, and that could be anything, what they're lifting, how they're lifting, and things like that. The complications for such patients could include hypersensitivity, in general, just being 9 months of ongoing sensory issues, adherence of the scar at the elbow, and sometimes you do see CRPS2. Literature, however, does show that most of the time the CRPS occurs in patients who have had revision surgeries and not necessarily with the primary surgeries.
That's great, Alpana. There was a question amongst the participants about the timing of therapy and how long we protect the ulnar nerve and immobilize the elbow. And Dr. Cassidy and I both answered that we actually like to get the patient moving immediately as long as it's done carefully and with protection. And I think you've talked about that, really nicely. I'd like to ask Dr. Binhammer if he's still here. What's your protocol, Paul? Do you immobilize these patients after the transposition, or do you try to get them moving? There's obviously a fine balance to be achieved between protecting the muscle repair, but also trying to prevent scarring along that nerve.
Can you hear me, Kyle?
We can hear you now. Thanks, Paul.
So I use a post-op soft dressing that allows them to move their elbow. I make sure, just like you, that when you done that, like, it's nice and loose, so I don't really worry that in it, so there shouldn't be any tension, and see them 10 days and take their saw off. I let them fully range their elbow at that juncture.
Great. Excellent. Becky, do you or any of the other therapists have more comments about rehab after ulnar nerve transposition or ulnar nerve decompression?
I think the really interesting question here that the therapists are asking is considering elbow position and forearm position. And so I'd love some more specifics. If you think about that repair after the submuscular transposition, Dr. Mudgal or anybody else, do you have a certain position of the forearm, pronation versus supination you like, and what position of the elbow? So what degrees do you prefer? How far will you let us move them is what I'm really trying to ask you.
Yeah, Dr. Cassidy, you want to answer that?
Sure, thanks. When I was training and early in my practice, due to my best friend and mentor, Jesse Jupiter, I did a lot of submuscular transpositions and we immobilized people for 3 weeks. And it turned out that a lot of elbows got really stiff. Yeah. And I think that all of the therapists would agree now that that motion for gliding of the nerve is very, very important. And so my practice has shifted all the way back to primarily in situ decompressions, and if the nerve's unstable, to subcutaneous transpositions, and infrequently I will do submuscular, but I will never ever immobilize the elbow, and I do not care about forearm rotation. And so, for example, when we do tennis elbow releases, we release the tendon. When we do elbow replacements for distal humerus fractures, we cut all of the common flexor and extensor origin, and patients do fine. So I really don't see a reason to immobilize the forearm in any particular position whatsoever. I do, with submusculars, place a wrist splint primarily just to remind the patients that they had a real operation, and not to overdo it. And that's the only reason. Yep.
Well put. Chai, do you want to have any last comments about that before we adjourn?
No, I think the session has been fantastic. And in terms of submuscular, I think I agree with Chuck. I really don't do submuscular unless I'm doing a revision. I'm more of a subcutaneous transfer. And I use Eaton's dermofascial sling. So I keep them in a splint only for comfort, nothing else really. Yeah. And I usually move them at about 10 days. I haven't had a chance to regret it yet. Who knows?
I will say that although I do subfascial slings, that's really best used in my opinion. I mean, obviously we're talking about a subluxating ulnar nerve, so I think an in situ decompression is probably not adequate. And so a sling is nice, but if you have somebody who's extremely thin like you are, Chai, there's really very little soft tissue protection on that medial forearm. And I've had patients who've had really significant problems with nerve irritation, not necessarily from resubluxation, but just from compression and from scarring in that subcutaneous tissue. For very thin athletic patients who don't have a lot of subcutaneous adipose to protect the nerve, I still do submusculars. But I think that subfascial, as long as it's done well and there's still a gliding surface, is very effective. Yeah. Becky, do you have any last minute comments for the therapists at the end? I want to thank everybody. All of the panelists I thought did a superb job. I think it was a really robust discussion. The cases were interesting. I thought the points that the therapists made were really, really helpful for me as a surgeon. I learned a lot, and I hope the panelists did as well. I'm going to share my screen one more time just to show the remaining sessions, if I can. Let me get there, because we do have a few more sessions left in this series, and I'd like to encourage all the participants tonight to attend. Here we go. And sorry for the awkward timing here. There we go, and share. So the next session on May 27th will be dealing with wrist pathology. Sorry, never mind. I will stop sharing. We have one more session dealing with wrist pathology That's what happens when you try to get a surgeon to do something that requires manual dexterity. On June 3rd, we have elbow, and on June 10th, we have a really fascinating panel talking about an international roundtable with therapy in some of the less developed countries and how some of the challenges are faced. And I encourage everybody to participate in that as well. So thank you all. Again, there will be a video sent out 24 hours later for tonight's session for anybody who wasn't able to attend the entire session. And you will get an email about CME credits down the line after the completion of the series. Thank you all very much and have a good night.